I welcome you all on behalf of DGF Infertility Committee for today's webinar on practical tips. We will be talking on IUI as well as on embryo transfer and on OPU also. So we will be talking on practical tips to optimize IUI results. Actually, this talk was to be taken by Dr. Sonia Malik ma'am, but because of our date change, because we were first planning to do it on 23rd, because of that she could not join. So that's why I took this. And when I was trying to prepare and when I thought I will prepare on IUI, I thought कितनी slide बनेंगी यार, 5-10 ही तो बनेंगी IUI में. But जब मैं करने लगी, then I thought कि हे भगवान, ये this is too long a topic and I don't think I have done justice according to me. इसमें बहुत सारी slides अभी और डल सकती थी. चलिए, to start with practical tips to optimize IUI results. Introduction. It is deposition of spermatozoa artificially in the uterus at any point above the internal os at the time when ovulation has happened or is likely to happen soon. So what is the rationale behind IUI? It is to bypass the hostile cervical mucosa. Reasonable efficacy of the procedure is there. That is why it is very popular, to increase the gamete density at the site of the fertilization. So, and there is no special training required for this procedure. Learning curve is almost nil for a gynecologist. It can prevent transfer of infection in cases of discordant couples, and simple, safe, and less invasive method. That is why it is so popular. So now coming on to the history of IUI. In 1678, first description of spermatozoa came, and it took almost 100 years before first IUI was done. The concept of ovulation was not clear. As a result, there was no success in IUI. First report of pregnancy came in 1793 in London by John Hunter. As with time, the ovulation mystery was solved and drugs for ovulation came, the process of IUI became popular. Earlier people were thinking that at the time of menstruation, ovulation was happening. So whatever they were trying to do, they were trying to do at that time. And actually it was not correct. That is why there were no results. Now, then using the data from the National ART surveillance system, at the Center of Disease Control and Prevention, it was shown that from 2004 onwards, non-IVF fertility treatment, including ovarian stimulation and IUI, became the most highly associated treatment procedure. But there was triplets and high order births that was reported in USA. Though in comparison to IVF, the success rate is less. But when we compare everything like cost, like accessibility, like the training behind that, then it is considered to be reasonably good technique. Now, what are the indications of IUI? Mild male infertility, unexplained infertility, mild endometriosis, severe vaginism, ejaculatory dysfunction, discordant for sexually transmitted infections like HIV, hepatitis B, cervical factor if present, immunological causes of infertility if are present, then ovulatory dysfunction if present, and when we need donor sperms. In those cases, we can do IUI. Now, factors which affect the IUI outcome. First and foremost important is the semen parameters, of course. Then age of the woman, her ovarian reserve, etiology of subfertility, superovulation versus natural IUI, then IUI timings, then technique, and number of inseminations you are doing, number of cycles you are doing this, and then what luteal support is being given to the patient. Then insemination parameters, we consider that how do you collect the semen, then whether it is being used fresh or a cryopreserved sample is being used, motile sperm count kya hai, and then volume of insemination, and then what is your technique. So all these are important for the outcome. Now, what are the unchangeable factors? The unchangeable factors in IUI are that you cannot change the age of your female partner. the ovarian reserve, what she has durability, duration of infertility, then etiology of infertility and tubal block if present, then this is not the indication for IUI. Certain factors which you can modify. These are drugs which you use for ovarian stimulation. Like if you are using oral ovulagens, then you can shift on to gonadotrophins. Then ejaculatory abstinence, semen collection, sperm wash techniques you can improve. Timing of insemination you can see. Then post-wash sperm motility, IUI technique, then type of catheter which you use, single or double insemination, bed rest following the procedure, and what luteal support you are giving. All these factors can be modified. Now, sample collection. Sample can be collected at IUI lab. There should be privacy, clean, proper, and total collection of the sample should be done. No lubricant should be used. No spillage. If there is any spillage, then you have to note it down that whether the first parts spilled or the in general there was spill or the later part spilled, and you should provide proper sterile labeled sealed containers to the patient. Then at home collection, the sample should reach you at 30 minutes. Do not refrigerate. It should be protected from sunlight. Sterile container should be used, and consent should be there for both partners. But now I would say, according to the new ART law, I think we should not entertain this at home kind of thing. It has to be done at IUI lab only now. Then what are the lab aspects? The quality should be taken care. It should be done under the laminar flow. The proper lab cleaning procedures are to be installed. And what is most important, that we should take consent also uh, of both the partners. The semen collection to processing time. When semen is collected at home, it should be delivered to the laboratory within 1 hour after collection, and while protecting it from extremes of temperature. Semen should preferably be collected in a private room near the laboratory. No pregnancy is reported if semen is processed more than 60 minutes after being collected. So now coming on to ovarian stimulation. I first thought to put something here, but then I thought that ovarian stimulation as such is a 1 hour lecture, so I should not be putting, here this ovarian stimulation. So, as I have shown that there are various colors of ovarian stimulation. So, what is ideal for us for IUI? For IUI, ideal for us is either monofollicular development or or as much as two follicles, nothing more than that. And if these two follicles are growing well, the simultaneous growth of endometrium is needed. As you can see in the picture, a good vascularity of the endometrium should be there. And if multiple small follicles are there and endometrium is not growing, then your ovarian stimulation is lacking. And then in those patients you may try another cycle, because if in these patients you will further give ovulagens, then you will form many follicles. So that is why we have to choose the drug which is right for our patient and go accordingly. The efficacy of different drugs for ovarian stimulation. Drugs that are commonly used for ovarian stimulation are the oral ones are clomiphene citrate, letrozole, and then gonadotrophins. Clomiphene citrate has a good ovulation rate of 70 to 80%, but pregnancy rate is lower as it has anti-estrogenic effect on endometrium and also hostile effect on the cervical mucus. Letrozole, wherein is giving us monofollicular development and does not have anti-estrogenic effect on endometrium or cervical mucus. It is very easy to use and it has very low risk of multiple pregnancy and ovarian hyperstimulation syndrome. So that is why letrozole is most popular, and now it has almost become the first line of treatment or first drug to be used. Gonadotropin seems to be more effective than either oral agents, as gonadotropins will induce multiple follicles as these women have no ovulatory dysfunction. But there are the increased chances of multiple gestation if you are using them injudiciously, I would say, because in all patients, if you are giving a guarded dose of gonadotropins, then there should not be this risk of multiple gestation. A recent systemic review and meta-analysis on pre-ovulatory endometrial thickness in IUI treatment showed that women treated with clomiphene citrate had a significantly thinner endometrium, and they, as when they were being given gonadotropins. So now, how will you give ideal is, I am telling what I am doing. My first line of treatment for the patient of IUI is to give letrozole. I start it from the third day morning, or sometimes on the second day evening also. I give 5 milligram 2.5 twice a day for 5 days. Usually I am not giving more than 5 days, but there are studies where people give more than 5 days. They are giving for 7 days or 10 days also when there is no follicular formation. But i usually I don't think we need that in a normal type of patient. So gonadotropin I add from day 5 and day 5, 6 and 7, 75 international unit only. And as per then patient is examined on day 10 most of the times, and at day 10 most of the times you will see a genuinely form endometrium, and comparable follicles, either two or one only. So now your further dose what you want to give, that all depends upon how your cycle is going, because you have to understand your physiology. If your follicle is, suppose your follicle has gone up to 15 now, and now ideally the follicle does not need any further dose of gonadotropins, and endometrium is 5 or 7 already, then the cycle is good, no need of drug. Suppose follicle is 13, then you may be tempted to give, suppose there are 2 3 follicles of 13, you may be tempted to give, I can give one more injection of gonadotropins. But when you see endometrium is only 3 4 so in those particular patient you can wait for 2 more days and then see how the which follicle is coming, and most of the times you will see one out of 3, either one follicle is selected and you will find a good endometrium. So there should be a, always should be correlation between what is going in the uterine cavity and what is going at the ovarian level. Suppose you are going very good follicles, there is good peripheral flow, everything is there, and there is no endometrium. So that means either those follicles are not giving estrogens or there is a problem at the target level. So you need to understand everything according to the physiology. So now monitoring of the cycle and trigger. The serial USG monitoring should be done from day 9 or 10 for endometrial pattern, thickness and growth of the follicles. Growth of follicle is approximately 1.7 millimeter per day, or at the most it is 2 milligram when you are giving drugs to the patient. Endometrial lining is most of the times 0.8 per day. Now, the double IUI versus single IUI. Single IUI has benefits of fewer visits, less cost, and less stress to the patient. And evidence suggests there is no difference in the clinical pregnancy rate between single versus double. Uh, the rationale of ovulation induction. In unexplained infertility, there may be undetected subtle functional defects in the follicular development, defects in maturation, ovulation, and luteal phase defects. Ovarian stimulation increases the number of dominant follicles and improves their quality, resulting in improvement in the pregnancy rate. That is why we are giving ovulation induction. In couples with unexplained infertility, the stimulated IUI cycles provide better results than the natural cycle IUI, that is 25%, 14% pregnancy rate. So now coming on to semen preparation techniques. One is swim up technique. other is direct swim up technique, and one is gradient separation. So the swim up technique is more popular, and most of the times this technique is being used. And then direct swim up, in this the centrifuge is done only once, but while in swim up we do it twice. That is the difference. And in gradient, there is it is used when there are more debris in the sample. So now, what are the methods of semen preparation? For normospermia, most of the times you use swim up after incubating, and then in non-viscous samples you can use swim up technique. Oligospermia, we prefer to do density gradient. Now, you will have good results in cases of unexplained infertility, cervical factor infertility, anovulatory infertility, and obviously in donor IUI cases. Poor results when severe male infertility or there is tubal factor. There are pelvic adhesions, though there is the tube is open, but pelvic adhesions are there, and in cases of severe endometriosis. Now, good responders are if the female is young, good crop of pre-ovulatory follicles are present, the endometrium form is good, and the sperms are good quality. Poor responders are older patients. Then they have those who are having longer duration of infertility, which is more than 5 years. There is poor ET formation, and then poor sperm quality. In those patients, the poor results we will have. Do we need to do ovarian stimulation in all IUI cycles? The pregnancy rate was lower in the natural cycle than in controlled ovarian hyperstimulated group. So there was no difference in pregnancy rate among subgroups of clomiphene citrate, then gonadotropins plus clomiphene citrate. Significant difference was not there in pregnancy rate. Then conclusion, the ovulation induction cycle could achieve a higher pregnancy rate than the natural cycle IUI done, whether you use CC, HMG, CC, HMG, or CC plus HMG. Particularly for the infertile patients under the age of 35 years, it is okay. But for the patients who are more than age of 35 years and infertility standing for more than 5 years, in those patients the gonadotropin cycles are preferred. Indications for natural cycle IUI is that donor inseminations when you have to do, then mild to moderate male infertility, cervical factor infertility, patient is not able to keep contact like vaginism and male problems, and female age is less than 30 years, then you can do IUI, but you have to counsel the patient about the results. Now, what are the timing of the survival of the germ cells within the body? Is that sperm stays for 3 to 5 days, whereas the ovum stays for only 24 hours. Now, the timing is more important for IUI than it is for timed intercourse. That is when you are making follicle and leaving the patient for having timed intercourse. The reason is that during intercourse, sperm travel through the cervical canal. There are glands and mucus in the cervix that sustains the sperm and acts as a reservoir of sperm into the uterus slowly over several days. During an intrauterine insemination, the sperms are released into the uterus. The sperm do not remain viable for as long a period, and consequently, the sperm must be inseminated close to the time of ovulation. one met One method to time an IUI is that an IUI that ovulation predictor kit can be used by the patient. The kit measures a woman's LH surge. The surge peaks about 12 to 24 hours before the egg is released. A woman will test her urine in the morning. If the test is positive, she would have the intrauterine insemination the next day. Another method is that we are giving the trigger, and we are using the HCG injection for that 34 to 36 hours or maximum 40 hours prior to the time of IUI. Now, when IUI should be done? After 36 hours of HCG or after documented ovulation, or along with the HCG, thinking that sperm will stay there for 3 days. So there are some fixed protocols, there are some variable protocols. The single insemination after 36 to 40 hours post HCG injection, and those people who are doing double insemination, they are doing it within 12 hours and then after 48 hours post injection. Then there are people who first do TBS and see that the ovulation has happened, and then after ovulation they will do the sexual intercourse before and after IUI. Intercourse before performance of IUI increases cervical reservoir of sperms and improves chances of pregnancy. Sperms can remain active up to 72 hours of entrance into the female genital tract. Intercourse should not be prohibited even after IUI, as it will cover a longer period. Specifically, if some follicle ruptures later after HCG trigger, as washed sperms are already capacitated and they will fertilize only 3 to 6 hours after the insemination. So that is the most important crux of this IUI. That is why we are doing it at 36 to 48 hours, because the sperms which you have now prepared and which you are putting into the uterine cavity, they are capacitated already. So they will be there, or they can inseminate up to 3 to 6 hours after you have inseminated. They can uh, produce pregnancy after 3 to 6 hours only. And the sperms which are there in the reservoir in the body, naturally they have gone, they will be there for 72 hours. So where to do and how to do IUI? Sample is maintained at 37 degrees centigrade in a tube warmer or held in fist, and identity of sperm sample is cross-checked. Waiting between loading and syringe procedure should be avoided. It should be carried out in a theater or similarly equipped room. Clinician should wear a cap, mask, means all aseptic precautions should be taken, and powder-free gloves should be used. Consent must you must visit the ICMR website to have the consent, and use that consent only now in the new ART law. Verify patient has what patient has given you, Aadhaar card, marriage card, marriage certificate, that you should verify yourself only. You should not leave it to your staff. Also take a consent that sample provided is by the male partner himself. Always take consent, because even if they have given sample in the room which is near your laboratory or which is attached to your center, then also they may have brought sample from home of somebody else and they are giving you what. So always take a consent that I certify that this sample is mine or my husband. Both partner signature you must take for your safety. Various parameters for doing IUI: cervical mucus aspiration, sometimes very tenacious, then some people are doing that, but I have never done that. Then full bladder, ultrasound guidance will be better. Passive straightening of cervix is done. Which type of catheter we are using, and volume of inseminate which we are using, and what should be the speed of insemination. The cervical mucus aspiration led to significantly increased pregnancy rates for women with unexplained infertility. That was study which was quoted in 2008. Does full bladder make IUI easy? The pregnancy rate was higher in full bladder group than in empty bladder group, 13.5% versus 7.4%. The risk of undergoing difficult IUI was higher in the empty bladder group than full bladder group. The clinical pregnancy rate was also higher in the group of patients who had easy IUI than in group of patients who had difficult IUI procedure. So to conclude, passive straightening of uterus makes the procedure easy. So that it is your discretion that you may keep the bladder half full, because sometimes there are adhesions after post cesarean. So go according to, just try to keep the uterine cavity straight on ultrasound. Ultrasound guided IUI improves pregnancy rates definitely as compared to non-ultrasound guided. Now, which type of catheter we use? So ideal insemination device should be deposit the volume without requiring a dead space in the injection system. It should be easy to use. It should be made of non-toxic material, semi-rigid, that fits into the curvature of the uterus, have a non-traumatic entry. It should provide mechanism to prevent the backflow of the injected contents. Soft versus firm catheter for intrauterine insemination. There was no evidence that this one is better or that one is better. But always, if you are using a soft and malleable catheter, then the negotiation of the os would be much easier and less traumatic. So what is the technique? Catheter introduction without touching walls of vagina. You try to put the catheter straight so that infection is not there. The IUI catheter is gently introduced into the uterus without force, without damaging the endometrium. But sometimes if there is a problem, stenosis, and your catheter is not going, you can hold with the Ellis forceps. Then technique, slowly inject sample over 2 to 3 minutes. What I do is we take almost zero point 0.8 or max to max 1 ml solution is there which I have to put. So I go thrice just doing, and when I put 1/3, then I wait, I count 60, then again 1/3, count 60, then again 1/3, and then count 60. After that, trying to remove the catheter. So if you are injecting it too fast, there is no place in the uterine cavity to take even 1 or 2 ml of fluid which is being pushed too fast, and that may come out into your catheter or outside as such. So how to remove the catheter? Catheter is gently removed, taking about 60 seconds, and then patient lies flat for 15 minutes. That should be okay. Now, alternative sites for IUI, whenever there is great difficulty in putting the sample at the precise position of C, then we can put the sample into the vagina or into the fornix. That can be done. At times you have to do it when it is very difficult to negotiate, then we go for hysteroscopy and then do the other procedures. But at that time, this is what you can do. Bed rest after IUI, moderate strength of the evidence recommends women undergoing IUI should have 10 to 15 minutes of bed rest after an insemination. Spermatozoa reach the fallopian tube as soon as 2 minutes after the insemination, and 10 to 15 minutes in mobilization subsequent to IUI will be enough. So now coming on to the luteal support, natural micronized progesterone is the preferred one, but however, we can use dydrogesterone also, and different routes of administration, oral, intramuscular or vaginal. Vaginal is considered to be the best. So now efficacy of luteal phase support with vaginal progesterone in IUI. The supplementation of luteal phase with vaginal progesterone significantly increases live birth among women undergoing IUI when receiving gonadotropins for this ovulation induction. Women receiving CC2 induced ovulation do not seem to benefit from this treatment. Now, does endometrial thickness after IUI outcome? The experience of some patients with unexplained infertility. The result was that 15.9% patients achieved a clinical pregnancy. Pregnancy rate increased significantly with increasing endometrial thickness on the day of the HCG and with increasing serum E2 levels, but were not significantly related to age, BMI, or follicle numbers. To conclude, the impact of endometrial factor in infertility may be underappreciated in IUI. So we need to see the endometrial vascularity and proper endometrial formation. So what can be done to improve the endometrial thickness? If CC you are giving, then we can delay the trigger for for ovulation induction, for follicle maturation. Then we can endometrium, once it's more than 7, then we can go. Or otherwise, people are using ecosprin, sildenafil, then estrogens. But once if you are starting estrogen, then please don't stop it in between, then we have to give it to the full cycle. And if at all you are giving, then 2 milligram will be enough. Don't go beyond that, because that is that will be giving negative feedback. That is why. Then hysteroscopy, if still no endometrium and good estrogen levels are there in the body. Does endometrial sampling affects IUI outcome? The RCT was performed in 150 patients, control group 1, and then the group 2 underwent tau brush endometrial sampling on day 8, 9 of the uterine cycle that preceded the stimulation cycle, and finally group 3, they underwent endometrial sampling on the 8, 9 day of the same cycle. The result percentage was 18, 38, 36 group respectively. So to conclude, endometrial sampling significantly increases pregnancy rates in IUI procedure, but when it is done in the proliferative phase of the IUI cycle or the cycle prior to IUI, then the pregnancy rate with IUI alone. But I have personally never done this in cases of IUI. Care after IUI, normal life, luteal phase support, instructed to call if abdominal pain, fever, onset of periods may if is there in between, and usually the periods are late by 3 to 5 days. How many IUI cycles you can give? Cumulative probability of conception after 6 cycles is 50 to 60%. Best results in first 3 to 4 attempts. Average monthly fecundity rates are 19%. So you just cannot define that these much cycles you have to give. It should be tailor made, and it should be according to the profile of the couple or profile of the patient, not as such blindly 3 cycles, 4 cycles you can't give. Now, predictive factors for pregnancy after IUI. To summarize, the couple with the best chance of pregnancy can be described as follows: under 30 years, cervical or anovulatory infertility, male with a count of more than 5 million. The ideal stimulation cycle enables the recruitment of 2 follicles, more than 16 follicle. E2 is more than 500 picogram per ml on the day of HCG. The best results when IUI is performed using a soft catheter, and that too ultrasound guided. Now, IUI is a teamwork. Clinician, gynecologist, ultrasoundologist, dedicated and trained lab staff, trained staff nurse, receptionist. Record keeping is very important now with ART law. To conclude, in IUI cycles for unexplained infertility, ovarian stimulation appears to improve outcome in pregnancy rates. IUI gives a higher pregnancy rate when combined with gonadotropin than oral agents. We need to review timing of IUI to optimize pregnancy rates. 5 million post-was sperm count appears to be the minimal requirement for successful IUI. So if you are doing IUI in a patient who is having 1 million this count and normal sperms less than 4%, then please explain, take consent, then do, because those patients are ideally not for IUI. Density gradient appears to be the method of choice for sperm wash in cases where there is oligospermia or there is too much of debris in the sample. Normally, routinely, so this your direct swim up method is okay, or swim up method is okay. IUI may be tried up to 6 cycles before moving into IVF or ICSI. 6 is the maximum limit. So take home message: proper patient selection, appropriate stimulation protocol, good quality lab work, meticulous procedure, luteal phase support, and if I may add, proper record keeping. Thank you.
Namaskar.
Namaskar, sir.
Namaskar. Excellent. Actually, you brought all the important factors which can improve the success rate of IUI. And despite all our efforts, the maximum you can attain is around 10 to 12% only. So that is one thing, because we must know what is the expected pregnancy rate. Otherwise, you go into depression yourself. When the pregnancy, and you have to counsel the patient accordingly, that IUI success rate is going to be this much only. And another very important point you brought out today, which is most relevant because of the new ERT bill, Aadhaar card, and because there should be, because a lot of live-in relationship couples will come to you, and and they will create problems subsequently and the person is the actual husband. And if in case it is a living relationship and they still want it, see, any woman can ask for a donor insemination, but then the sample has to come through the ART bank, not directly in your center. That is another factor. And now, most of the time, gynecologists are busy when they're doing IUI, and embryologist has prepared or the technician has prepared the semen sample, and the semen sample is lying for some time in the incubator. And then so timing is very important, that after the preparation, don't wait for a very long time. Otherwise, the ROS will increase and that will decrease the pregnancy rate. So after preparation, one should do the examination as early as possible. It should not be kept in the incubator for a long time after the semen has been prepared. And you also mentioned very well, the cervix is the reservoir of the sperms in a natural intercourse. So in cases, where you want to, especially when the male factor is there, you don't, even the post-wash count may not be 5 million actively motile sperms, but still, you have to do it. So you do the insemination and the pellet, whatever is left with you, you can just put it at the external os. Don't put it in the canal, just leave it at the external os. So whatever sperms are there, they will penetrate the cervical mucus and that will add into the sperm population in the uterine cavity. So that way, even with a less sperm count, you can do it. Or you take two semen samples and pooled semen samples in the patient. Sometimes, the earlier reports are okay. On the day of IUI, you find the count is the 7 million or 8 million, and out of that, 50% are dead. So what to do? So under those circumstances, you can do the pooling of the semen sample. Take one sample, prepare it. Another sample, you take it, prepare it, and then pool it. And then, you will have a better concentration of the sperms. Now, after the IUI, the patient should be asked to lie down for some time. The reason being, sometimes, the prostaglandin levels in the semen samples are very high. And even after washing, the prostaglandin levels are high in that inseminate, and patient can have severe cramp and vasovagal attack. So if anything has to happen, should happen in your center only. So better, at least for half an hour, let the patient lie down in the, not that you do the examination, send them home immediately. Because otherwise, rarely, patient may have a vasovagal attack because of the uterine severe contraction because of the high concentration of the prostaglandins in the semen. So I think overall, counseling the patient, the success rate of the IUI, and taking the proper legal precautions today, and as you mentioned, the documentation is very, very important, to practice intrauterine insemination in the center. Thank you, ma'am.
Ma'am?
Yes. I think your presentation had been absolutely great, covering all aspects. I will just touch few points. Now, one thing about how much follicles you want. I think it should never be more than 2 or 3 maximum, and that it all depends upon what is there. Our main aim is monofollicular. Then letrozole, as far as things are concerned, we must remember DCHI recommendation is only 1 tablet for 5 days. So in case if you're using the double dose, as we all use the double dose, 1 week for 5 days, please do not put down on the paper which you are giving it to your patients. You just have letrozole for 5 days. Don't write down BD or OD, otherwise you can be caught. That is another thing. As far as the monitoring part is concerned, in case if it's just simple letrozole and clomiphene day cycle, you can just do an ultrasound on day 12 also. That should be good enough. And if you're combining is oral ovulations with gonadotropin and combining, then you can do it earlier on day 9 and then again day 12. As far as the endometrium is concerned, I think our dictum remains the same, whether it's IUI or IVF. Less than 7 millimeter, it is no good. You discussed about the preparation. I think it has been absolutely great. The only thing which I wish to tell you is that from the time the person has given the sample till the time it is put back into the uterine cavity, it should never cross 90 minutes. I again repeat, this time is 90 minutes from the time he has ejaculated till the time it has been put after processing. It should never be more than 90 minutes. As far as the instructions in the previous bill and now, which has been there, it was always that the sample should be produced in the clinic or IVF center. Yes, and now it is absolutely there. And you know, if the sample has come from outside, you must record the sample has been brought from home. चाहे कितना भी है, it must be recorded that it has been brought from home, because कल कुछ कोई किसी तरह की कोई problem हो जाएगी, then you are not responsible. You have to only write the sample was brought from home. As far as the luteal phase support is concerned, I feel that, you know, in clomiphene and letrozole, you need not give any luteal phase support. But in case if the gonadotrophins are added, then the luteal phase support is required. You asked about the timing of it, and I strongly believe in single IUI, unless it is a male factor or a donor specimen you are taking it, then we do a double IUI. That, you know, we do it around 12 hours and then post-ovulation. Timing is always, it has to be post-ovulation. But in case if you happen to, you know, you call in your, unfortunately, the gentleman has also given a specimen and it is not ruptured, then in that particular case, I always call them the next day for a repeat IUI in such cases. And we ask the history, then in case the pain was there, the patient felt the pain soon after you had done IUI within 6 hours, then you don't need to do another IUI. But if this particular pain which suggests an ovulation rupture, it has to be either in the middle of night or early morning, then you have to repeat the IUI. So that is the indication for second IUI. Now, another factor which you just now mentioned, just 1 minute. Optimum time is over. That's it. Now, I think it's a good practice that, you know, in your OPD waiting area and the consultation chamber, you must write down the success rate. If you're just monitoring it by for follicular monitoring and you are doing an IUI, the success rate is only 6%. If you're not given any stimulation or oral ovulation, then again it is 6%. You can just doing simple IUI. Clomiphene plus IUI is 8%. Letrozole and IUI is 8%. If you combine oral ovulation with gonadotrophin, it is 12%, 10 to 12%. And it is gonadotrophins with IUI, it is combined, makes it 17 to 18%. And there also you must down on the success rate of IVF. Self-cycle with good reserve, it is this much success here. No, it must be there. So at least when the patient, you always counsel them about the success. But, you know, वो वाली बात सुनते ही नहीं है, उनको वो यही सुनता है कि 100% सक्सेस होगी. तो आप उनको दिखाओ कि ये बाहर जो ये क्या लिखा है, ये हमने आपको उस दिन भी बताया था, अभी भी बता रहे हैं कि this is what the success rate is. And I think it's always good to tell, always good to file there that you have done a counseling about the success rate in IUI as such. So these are the 2 points which I wish to tell you. I find, you know, unfortunately, many people still do not get semen examination prior to IUI, and many times it has happened, and I think this should really not happen. You must, the patient, female partner requires as many examinations. The similar way, the gentleman must be also examined, and his 2-3 samples must be there with you. So I think with these remarks, I will say it was great lecture.
Thank you, ma'am. Dr. Jyoti?
I just want to add one point. You know, if the person is getting the semen sample from home, we will take a certificate from him that he has brought the sample from home and it is his own sample. But if he is giving in your lab, if you take such a certificate that is his own sample, though he might have given some other friend's sample, so you will be caught. So that certificate should not be taken from him when he is giving in your center, because once he has given the center, he has absolved himself that now it is your responsibility.
पर सर वो घर से भी तो ला सकता है ना, आपको वही ट्यूब में डाल के दे दे तो क्या करें?
So I'm coming to the next point. See, whenever we are counseling the patients, we see that this person is a chatak chalak. So under those circumstances, take one semen sample out of the blue. Don't tell him or prepare him to that okay, third day, fourth day we want to do the semen analysis. You take the semen sample and freeze it, because by body language this person is going to create problem. So that patient, you may be increasing the cost of your to yourself, but you save yourself from all the problems later on. So under those circumstances, you freeze the semen sample, let him give the fresh sample on that day, but use the one which you have frozen it earlier, without giving him a chance to bring the sample from outside. Because now this is going to be the biggest, problem to us as an IVF specialist. The patients will, take the money of the treatment, the education of the children, the marriage of the children, and for the old age home from you by doing all these hanky-panky things. So you have to be a step smarter than them. So take the semen sample, just suddenly on one day say, okay, I want to see a sample. And if he gives it easily, because if the person is, shamming it, no, today I cannot give, this, that, or not been able to give, that is the person who is suspicious. So that person has to be very careful when he gives the sample on the final day. So make sure, that nobody accompanies him, or, the body check, we can't do it. I do not know how legal it would be to do the body check if he has brought some sample from outside. But definitely, one can make out, or, the another best way is, like if you suspect that, this may be a problem, you take the first sample and then say, okay, there's some problem in the sample, you please give another sample after 2 hours. So he'll have no time to go back home and get a friend sample again. So precautions, because the new practice, we have to be very careful.
Good. Won't the count be affected in the second sample? Won't it be lower?
No, it will be. It may not be lower. It may be lower, but it will save your skin, because what you need is 5 to 6 total motile sperm count.
Right.
You don't require very high.
And many times patients ask, can they keep their normal relations after getting an IUI done?
Oh yes, oh yes, oh yes.
Normal.
Okay. No restriction.
Dr. Jyoti?
Thank you, Dr. Poonam. In fact, your presentation was so nice with such beautiful slides. And after hearing all the tips and tricks from the stalwarts, I have nothing much to say except we should keep the IUI very simple and cost effective. We should not make it very complex. And tips have been well shared by Sharma sir and ma'am. And your take home message, I think सब लोग पूरा घर ही ले जा रहे हैं अपने घर में. And in your last slide, and many people do IUI ultrasound guided. Studies have shown that there's not much improvement whether we do it ultrasound guided or without ultrasound guided, but some patients may be benefited because they want to see everything, and just for their sake we can do it ultrasound guided. It will just take 1 minute extra to do it, but it may help the patient. This is what
Thank you. Dr. Vandana?
Yes, it's a wonderful presentation and really good take-home messages and completed by sir and ma'am. So only one question I had that patients do ask about their normal relationships. So that can be carried on in food.
That
and
can be carried.
that is what they ask. Food हम क्या खा सकते हैं? कुछ हमको restriction रखनी है कि नहीं? So nothing. Just carry on with the normal life.
Just normal life.
Normal.
Doctor, I will tell 2 more points. One thing is, patient do ask, we always tell them it is your natural cycle, supplemented with little bit, by the doctor's aid. Once they have stopped their periods, I always tell them to have a regular relationship at least every 3rd day. And IUI cycles, I think it is must for you to tell them. And once the IUI has been done, we always tell them to have relationship. In fact, we insist on it that they should have relationship. Secondly is that even if there's IUI has been failed, we tell them to have a normal relation the next cycle. It is not surprising, just like IVF, that a patient may not conceive in the IUI cycle but may conceive later. Thirdly, I am very clear. I think I may be commented by Dr. Brigadier Sharma. Whenever you are trying to do IUI, the count, if it is less than 10, you must write down patient is for IVF. If the count is less than 5, patient is for ICSI. So this is the message must go with them, that your count is low, and if it is too low, then you are not the candidate for IUI, you are candidate for IV efficacy. So this particular part also should be told to them.
Just trying to share my slides. It's already 5 p.m. Should we go ahead, ma'am? करना है कि अगली बार करना है? Dr. Poonam has very well covered each and everything, I think. But वो home collection वाला जो point है, we cannot, kind of
नहीं कर सकते
take it
हम।
off altogether because there are some patients who cannot collect in hospital premises. So a special consent form we also have, which we get signed for such patients. And कुछ लोग तो affidavit भी बनवा रहे हैं, but हम लोगों ने affidavit तो नहीं बनवाना शुरू किया. But I heard some IVF centers saying this, that whenever home collection is done, they are getting affidavit made that it's patient's husband own sample. So that can be thought about. And ultrasound guidance ka Dr. Jyoti ne already mentioned kiya, because literature doesn't support that ultrasound guidance improves. But yes, it becomes so easy when you see half bladder full hai, uterus pehle hi straight ho jata hai. So the procedure becomes very, very easy. And another thing is, I tell patients to keep contact even on the day of trigger. So day of trigger, and then because generally 36 to 40 hours के बाद IUI कर रहे होते हो, then IUI, and then contact that day and next day also. And as per, if the follicle is already ruptured, so same night patient keeps contact, and then I start vaginal preparation next day. और अगर मैं अगले दिन भी कांटेक्ट रखने को पेशेंट को बोल रही हूँ, बिकॉज प्रोजेस्ट्रॉन स्टार्ट का जो डे है, दैट इज ऑल्सो लिटरेचर सेज ईदर ऑन द डे ऑफ IUI, एंड यू कैन स्टार्ट विद इन 24 to 48 hours ऑल्सो. So if I'm telling my patient to keep contact next day, then I start vaginal preparation the other day. उसके भी बाद अगले दिन से फिर start करते हैं. I think you very well covered each and everything. Shivani can add something.
So what is your choice for the luteal phase support?
Ma'am, I give vaginal progesterone. Dr. Poonam,
vaginally हम देते हैं, vaginally देते हैं, preferably vaginal.
Some patients who feel troubled putting vaginal, then I give them dydrogesterone.
हाँ, dydrogesterone.
Dr. Jyoti?
Oral luteal support, dydrogesterone.
Dr. Shivani, your comments.
Shivani,
unmute, please.
Sorry ma'am, comments on progesterone?
नहीं, IUI पे journal है.
हाँ, no, I was listening to everyone and Dr. Poonam, बहुत ज़्यादा आपने मेहनत करके इतना डिटेल स्टडी का आपने प्रेजेंटेशन बनाया है, so that is really good. And I just wanted to answer. Somebody has put up a question about sildenafil in IUI. What is the role of sildenafil? तो डॉक्टर पूनम आप ही बताइए, sildenafil का क्या आपको मिला IUI में?
There is no role as such, but people are giving. देने में कोई नुकसान नजर नहीं आता, तो that is why people are giving. Actually क्या है, after suppose I am seeing the patient on day 9 in a clomiphene cycle, endometrium होगी नहीं, अगर मैंने start कर भी दिया sildenafil, endometrium थोड़ी बहुत तो आनी ही वाली है, तो it is coming because of that or as such it is coming, we don't know, and literature doesn't support all these things.
ठीक है, थैंक यू. और मैम मैं एक चीज लाई हूँ अपने पास. दिस इज ट्रांस मायोमेट्रियल एम्ब्रियो ट्रांसफर के लिए हमने ये बनाया था, बिकॉज वो टोवाको कैथेटर तो बहुत महंगा है एंड ही इज नॉट सेलिंग लेस देन 50. सो मेरे पास एक वीडियो भी है, सो आई थॉट कि आई विल शो दिस एट द एंड ऑफ डॉक्टर सुनीता's लेक्चर.
So we are going to.
चलो आप रखना, हम नेक्स्ट टाइम वो बताना, दिखा देना हमें.
हाँ.
Who has made this? You have made?
हमने डिजाइन किया, बिकॉज जो टोवाको है कैथेटर ट्रांस मायोमेट्रियल वो तो मिलता नहीं है इंडिया में. उससे बोला मिनिमम 50 तुम इंपोर्ट करो, तो लैक्स ऑफ रुपीस कौन खर्च करेगा, तो हमने ही डिजाइन किया है ये थी, और हमारी ट्विन प्रेगनेंसी हो गई इससे.
क्या बात है.
वेरी नाइस.
थैंक यू.
डॉक्टर पूनम, एक और चीज जो आपने बोली कि आप 5 दिन ओरल ड्रग देने के बाद देन यू गिव 3 doses ऑफ गोनाडोट्रोपिन एंड देन यू आस्क योर पेशेंट टू कम.
नहीं, देन नहीं, डे 5 से गोनाडोट्रोपिन.
हाँ, तो नहीं, लेकिन अगर आप पेशेंट को बुला के पहले फॉलिकुलर मॉनिटरिंग रिपीट करते हो या स्ट्रेट अवे यू टेक?
स्ट्रेट अवे.
So this is what I don't do, because every patient behaves differently. Sometimes they bloat up on letrozole only. So I make it a point that if I'm adding gonadotropin, then I go slow on gonadotropin as far as IUI cycles are concerned.
Alternate day you give.
Yeah, alternate day, and I would like to do an extra scan to keep a check that the follicles don't, because otherwise you sometimes may have to cancel the cycle because of too many follicles or too many intermediate follicles also.
Day
Doctor,
9
I
पे
think
I do
I
the
think I
scan
will differ
mostly.
here, because in case if you are using a gonadotropin, alternate days treatment does not work. Just like IVF, you have to give on daily basis. I will like to have Brigadier Sharma's comment on this,
नहीं,
because
मुझे भी
once
लगता है मैम अगर देना है तो वो रेगुलर देना है, नहीं देना तो नहीं देना.
नहीं,
I
लेकिन
agree.
रेगुलर देने से ना पेशेंट कई बार बहुत सारे इंटरमीडिएट फॉलिकल्स बना देता है. सो रेगुलर
डॉक्टर अगर आपने इसको लेट शुरू किया है तो फिर तो और ऐसे छोटे मोटे फॉलिकल नहीं आएंगे डॉक्टर साहब. जो बड़े फॉलिकल हैं जिसमें पोटेंशियल है वही बढ़ेंगे.
मैम अगर पेशेंट का ना एक पर्टिकुलर साइकिल में रिस्पॉन्स इज, आई हैव सीन द रिस्पॉन्स ऑन इंटरमीडिएट डोजेस and the response I have checked that it is not being, she is not getting bloated, then next cycle I will use continuous if she did not conceive in that. But very first cycle I am extra cautious. Somehow I don't give continuous gonadotropin, or even if I am giving continuous gonadotropin, तो मैंने अगर आज gonadotropin लगाया है तो मैं कल बुला के एक बार फिर चेक कर लूंगी before telling her take another one.
नहीं, फॉलिकल मॉनिटरिंग तो आप जैसे फ्रीक्वेंटली करना चाहें उसमें कोई खराबी नहीं है. पर माय प्ली वाज दैट डोंट यूज अल्टरनेट डेज. व्हाट शिवानी, व्हाट यू हैव टू से?
शिवानी म्यूट है.
म्यूट है, म्यूट है आप, म्यूट है, म्यूट.
हाँ नहीं मैम, आई अग्री विथ यू. ये जो ऑल्टरनेट डे है, दिस इज समथिंग फॉर कॉस्ट फैक्टर. आई हैव नॉट रियली बीन एबल टू फाइंड एनी अदर लॉजिक, एंड वी ऑल नो कि हाफ लाइफ पॉइंट ऑफ व्यू it has to be every 24 hours. So if I want to give only 2, then I'll give day 8, day 9, but I will not do alternate day, day 6, day 9. ऐसे नहीं.
Somebody is asked, do you need and require a marriage certificate for IUI? No, we don't do that.
But Aadhaar card should be sufficient. Aadhaar card is definitely required. And the problem is, most of the people, the girls may have a Aadhaar card address of the father's house, may not be of the same, husband-wife's house. Then that is the problem, because we really don't know that she is really married to that person. Husband has got a different home address and the wife has got a different home address.
Sir, आप कैसे देते हैं gonadotropin? Always continuous?
Yeah, normally I give continuously. These protocols way back in 90s, it had come when we were giving alternate day. And that time, because gonadotropins were also costly and they were not easily available, that is the time when we used to give it alternate day. Nowadays, the rates are also okay. So we are giving it every day, because no point, taking the patient on a roller coaster phenomena of high FSH and low FSH. It is like, costing alternate day. So that doesn't really give you any the same. But only thing is, if you are giving a letrozole, then you can straightway call the patient on 9th day instead of calling on say on 6th day or so. Because otherwise, you will tend to add on to the gonadotropin early, because the aim is to have a monofollicle growth. So by 9th day, the dominant follicle is already selected, and that is the time you can add 1 or 2 days of gonadotropin. So the cost of treatment will reduce, and secondly, you will not have more than one follicle. Don't call them very early after 5 days, or 6th day only you call after the letrozole. And this letrozole dosage, if the patient is thin, I prefer to give 2.5. It's only in the obese patients I give 5 milligram.
Okay. Anybody wants to? Dr. Rajkumari Bukaria wants to say something. Dr. Raj?
No, madam, I am
Anybody
just learning.
Okay. And Dr. Ila, anybody wants to make any comment?
वो अरुणा दिखे थे मुझे, डॉक्टर अरुणा सक्सेना.
Dr. Poonam, sorry, मैंने अभी join किया, just missed the entire
Okay,
thing.
perfect.
So I was
So,
busy with the patient
I
actually.
think we should wind it up. And thank
I
you very
want
much.
to-
It was great, Dr. Poonam. Whatever has
Thank
been
you,
added,
ma'am.
you now add up, a couple of slides in your presentation.
Sure. ठीक है मैम.
Thank you so much.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am. Thank you.
Anybody wants to make any presentation, Dr. Aruna? You want to make any presentation, but because Dr. Arora will make a presentation, what about you?
Ma'am, yes, next time I can make.
Yes,
I can
okay.
talk to you.
Right.
हाँ चलो मैं I will call you. We will discuss